All right. Thank you, everybody, for joining us at the ASMBS Bariatric Happy Hour. My name is Laura Fisher. Julian Lloyd and I both host this session once a month, and we alternate between Journal Club articles and the video sessions. So tonight we're going to be talking about finding a job, which I'm sure all of you have had the wonderful experience this year towards the end of your fellowship. And the title of the article is Analysis of Early Job Market Experiences and Perceptions Among Bariatric Surgery Fellowship Graduates and Bariatric Program Directors from Obesity Surgery. So we have our presenting fellow is Dr. Liz Sodomin. She is a minimally invasive complex abdominal wall and bariatric surgery fellow from Penn State Health. And let me go to my introductory notes. She began her medical training at the Lewis Katz School of Medicine at Temple University and graduated in 2016. She also has, besides an MD, a Master's of Art in Bioethics. She did her general surgery residency at the United States Air Force in Las Vegas, Nevada at the Kerkorian School of Medicine, and then was stationed at Nellis Air Force Base and worked at the Mike O'Callaghan Medical Center prior to her honorable discharge in July of 2020. After this, she joined Penn State and is completing her fellowship training. Our guest discussant this evening is Dr. Yijun Chen. He is an associate professor of surgery from the David Geffen School of Medicine at UCLA. He grew up in Hunan, China, and attended the 4th Military Medical School in Xi'an, China, and then came to the United States to do cancer research. After doing his postdoctoral training in cancer biology at Stanford, he completed a surgical residency at Stanford University and then found his passion in bariatric and minimally invasive surgery. He did his bariatric fellowship at Duke University and then joined UCLA. And he really enjoys connecting with and developing partnerships with patients. And then our second guest discussant also helps to chair the Bariatric Surgery Training Committee, which puts on these sessions, is Dr. Kunnor Jain-Spangler. She is an associate professor at Duke University. She did her medical school at Medical College of Virginia, her residency also at VCU Medical Center, and did her fellowship at Duke University and then stayed at Duke. In Googling her, found out that she speaks 4 languages, which is super cool and very badass. And on the website, she says that outside of work, she enjoys spending time with her family, going on adventures with her son and her husband, including camping, skiing, going to the beach, and boating. And she loves cooking, reading books, and playing in the woods. That is her. And I'm going to stop sharing my screen and pass it over to Dr. Sodomin, who's going to present our paper this evening. And after the presentation is completed, we will move on to having a fun and very informal discussion on finding a job.
All right, can everybody hear me? Good. All right, fantastic. So we've already gone through the intro. Tonight is going to be discussing on finding a bariatric job. We already had the paper introduced here as framed. This is going to be an analysis of the early job market experiences and perceptions of the fellows and bariatric surgery program directors. So the initial hypothesis that was evaluated was looking at recent graduates and determining if there was increased difficulty with their job search due to fewer available opportunities. The primary objectives of of this paper was to look at and characterize the employment patterns and opinions among the bariatric fellowship candidates over the past decade, as well as to characterize the experiences and the opinions of the fellowship directors. To give a brief background, there was a significant increase in bariatric surgery volume, initially from 1998 to about 2006. Looking back then in the last decade, there's been continued growth of the volume, but it's been relatively modest and is currently outmatched by the number of bariatric and MIS fellowships. These fellowship positions have continued to increase steadily over time. And at the time of this study, which was completed in 2019, the Fellowship Council had reported 116 official spots at that point in time, which does not account for all of the unofficial spots that also exist. To transition to another study that was done to look at the projected 2020 cases that came out of the study listed here, you can see the case volume is continuing to progress up to 2019, whereas we have our impact from the COVID pandemic in 2020, and you can see the subsequent drop off in number of cases. That had continued impact throughout our training for sure, and we'll discuss that a little bit later throughout our discussion here tonight. The study design itself was a retrospective cohort survey. This was done through the fellowship graduates and program directors from 2008 to 2019. Initially, 996 graduates and 143 program directors were identified. They were then surveyed electronically, and the response rates were about 9% for the fellows and 20% for the program directors. So the final study comprised of 88 fellows and 29 program directors. They then subdivided the fellows into early and recent graduates. The early graduates were the 2008 to 2016 subgroup, and then the 2017 to 2019 subgroup were characterized as the recent graduates. The early graduates comprised 36 individuals, whereas the recent graduates were 52. The survey questions that were sent out are all listed here. I'll just give you a brief overview of that. So the initial survey that was sent out to the fellows looked at the demographics, then looked at their job search characteristics, then looked at their current employment, and also comprised of agree, disagree summary questions. The survey that was sent out to the program directors was a little bit more condensed. This looked at the programs themselves, where they were located, how many fellows they had, what the program was characterized in terms of cases and volume and numbers, and then also looked at an agree, disagree summary questions. From this, the results that came out of it, looking at the demographics for the fellows, there were 69% males and 30% females in the responding individuals. Regional representation was similar to where we have our fellowships located, spread throughout the United States. In the initial practice settings results, they looked at whether people had stayed at their residency program or fellowship program. More than 80% of individuals said no, they were outside of those locations. Additionally, looking at whether they were at their desired setting or not, 76% said yes, 24% said no. Of those who said no, 33% wanted to be in a different geographical area. An additional 33% reported that they had suboptimal cases or practice volume, which led to their undesired location. 4% stated that their salary was inadequate, and 7% said that they didn't have adequate partners or administrative support. Looking at the case volume more in depth, then you can see in figure 1 here, they looked at the ideal volume versus the actual percentage of bariatric case volume. So you can see the percents listed here on the x-axis and the percent of individuals who reported this on the y. You can see that in terms of actual case volume, the highest volume was actually in the less than 25% of bariatric cases. Also, when substratifying between early and recent graduates, figure 2 here shows that the recent graduates had a more difficult time than the early graduates in terms of finding a job, being employed as a bariatric surgeon, as well as volume and satisfaction. Overall, in terms of their agree-disagree survey questions, those who had moved forward into bariatric practice did have significant positive responses. 91% felt that they were adequately trained to practice independently. 95% said that they were content with their choice in a bariatric fellowship. 72% said they were satisfied with their work-life balance, and 84% agreed with the fact that they were marketing themselves as a bariatric surgeon. When then looking at the program director evaluation, this is in terms of their agree, disagree, 86% reported that their graduates over the last 5 years had found bariatric jobs. 79% agreed that it is more difficult to find a bariatric surgery job compared to 5 or 10 years earlier. And 48% of the program directors actually agreed with the statement that we're training too many bariatric fellows. The major findings that came out of the study then were that there is an increased difficulty in the job search and obtaining a bariatric job, specifically towards the more recent graduates. Additionally, bariatric cases are not increasing in volume equal to the increase in the trained number of bariatric surgeons. The paper then made the point that there's a need for improved access to care, and the roles in rural or underserved populations have to continue to be explored. And then additionally, that case volume can be insufficient in our recent graduates. The limitations of the study, of course, given that this was a retrospective survey looking back over 10 years, would be both responder and recall bias, as well as the low response rate. As we discussed earlier, only about 9% of fellows responded. Of course, if they no longer have access to their university emails from when they were a fellow, they probably didn't even get the survey. So additionally, improvements would be surveying a larger cohort or response collection over time, such as like an exit interview, allowing you to then have this data accessible throughout the timeline. From this study, think about what we can look at in the future and what implications it has. Certainly looking back at the COVID-19 pandemic and the implications of that as the study ended in 2019, and then we've experienced this thusly. With the difficulty in finding a bariatric job, the COVID-19 pandemic only worsened this. There's certainly now a backlog of surgeons who are probably not in their optimally desired position, at which point they are now looking for new positions that we've come to the end of our pandemic, conflicting with the current fellows finding their own jobs as well. And to touch on a newer thing, our GLP-1 inhibitors and the marketing associated with them in terms of medical weight loss. I've put a couple article titles here just from a quick Google search as to how these are marketed and how they're the new medical bypass and how obesity treatment has been revolutionized by these drugs. Of course, we don't have the data to say that. We can say longitudinally, our bariatric surgery lasts, there's diabetic control, et cetera, et cetera. However, with the marketing and as these drugs continue to progress across the market, how are they going to impact our jobs? And then as the paper brought up, what are we doing about insufficient access to care? How are we addressing referrals, insurance coverage, and then also patient perspective in order to augment our case volume? So we can turn this over to our guest speakers at this point.
Yeah, that was fantastic. Thank you so much for doing a really nice summary. And as you were talking, I kept thinking of so many points that we can potentially talk about for sure.
Absolutely.
If you want to stop sharing your slides, that'll make everybody look bigger so we can see your faces. And for all of our participants, fellows, other faculty attending, if you have a question, please put it in either the Q&A or the chat, and we can answer it either live or in the chat box. And if you want to ask a question live, just let us know and we can upgrade you to be a panelist and we can put you on. So I'd love to get comments from Dr. Chen, who was the senior author, and Dr. Jain-Spangler as well. And we can kick off with a rousing discussion on the worst part of my entire life, which was finding a job.
Thanks, Laura. And Liz did a great job. That's a great presentation. Yeah. So I'd like to talk to everybody about the background. Why did we do this study? This initially was my idea. What prompted me to think about this? I want to share this story. And I was trained at Duke between 2013 to 14. Kunnor was a year before me at Duke. At that time, we had this bariatric training session in San Diego, nationwide. I think about 70 or 80 the MIS bariatric fellows got together in San Diego. We had this industry training. So I was there. I was very happy. I saw many of the co-fellows from other programs, and we kind of keep in touch with each other for a little bit. And then after that, I go to ASMBS meeting every year, nonstop, except the pandemic. Yeah. And one thing I noticed that every year I see less and less those co-fellows. It's shocking. I think the last 2 or 3 years, I pretty much see 2 other fellows from the same year. Finding 1, finding 2. I realized that in my year, I was looking for mostly academic jobs. Nationwide, there were like 3 or 4 academic job opening. We had about 180 or 100 fellows. That was very small amount of jobs, number of jobs. And then I was trained at Stanford for residency, and I know quite many of my friends from Stanford and from other places who went to the very good fellowship and got a bariatric job. I'm talking about those people who got a bariatric job. Even among those, very sadly, I see quite a few of my friends actually quit doing bariatric surgery for all kinds of reasons. Yeah. So at least 2 quit doing bariatric surgery. Another one is doing minimal bariatric surgery. That's among pretty close friends of mine. So all those things prompted me to think is that, are we training too many fellows? So with this question, I went to the ASMBS Bariatric Training Committee. As a non-member, I was not a member of the committee, but I know Kunnor, I know quite a few people there. Kunnor, I have this idea. I want to share my idea. So I went there, and talking to the committee members, I say that I do this issue, and it's very interesting that the past ASMS president Scott from Brigham, what's his name? Scott Shikora. Yeah, he was at the meeting. I told him that I think we're training too many fellows. The fellows are having a hard time finding jobs. Shikora was like, we know this 10 years ago, but we can't do anything. Dr. Matt Harder said that we kind of also know, but the problem is that as a society, we cannot say that we need to cap the number of fellowships that in. This is market economy, and free competition. You cannot do monopoly. Then we discussed at committee finally everybody agrees that how about let's get some data. So get some data, then we think about what to do next. So that's the background behind this paper. Kunnor, do you have anything to add?
Thanks, Yijun. I just want to add, Liz, I thought you did a phenomenal job. Thank you for presenting our paper well and for really understanding the gist of what we were thinking and where we were going with it. And so when Yijun first came to me with this idea, I kind of took it and ran with it as far as like, okay, Yijun, this is a great first step, but we're going to take this and do it. And then in a couple of years, we're going to redo it. And then in a couple of years, we're going to redo it, because this data is really important to, as far as becoming a stepping stone for how we structure ourselves as fellowships and what requirements we have or don't have. And Adrian and Laura and I were at the ASMBS Bariatric Surgery Training Committee earlier tonight, and we're talking about, number requirements and scholarly activity requirements, and what does it mean to be a bariatric surgery fellow, and what are the requirements to do that and get a certificate. And these are all very complex things. This is a very inclusive society and a very inclusive program, and we want to stay that way. And at the same time, if we're only growing by 20,000 cases a year, but we're adding, 100 fellows every year, it becomes difficult as far as everybody having enough cases to do. I do think it's really important to point out, one of the things that Liz mentioned is that, I think this probably, I'm a glass, my glass is always full, not even half full. My glass is just always full. And so this is why Yijun and I make great partners, because he's convinced that the world is going to end. And I'm like, no, that's just a little bit of drizzle. The sky's not falling. So I think this speaks to the resiliency of bariatric surgery fellows and minimally invasive fellows, is that despite people saying, I didn't get the cases I want, I don't have the job that I necessarily want, we're still happy. The vast majority of these people still said, I like my job and I'm happy, which I think is pretty remarkable. And will be interesting going forward. We're thinking a lot more about surgeon wellness and burnout and just death by 1,000 cuts and all of the things that have been discovered during COVID and all of these meetings that really could have just been emails. And so I think it will be interesting moving forward to see how that really does pan out and what true happiness is and how much it relates to doing the exact cases that you want to do, and how much of it is really just being trained and having that skill set and being confident in what you're doing.
So one thing I want to add is that I think we have some data. It's not perfect. Another story was that it's very interesting. Once we got the data, we sent to one of the journals. I don't want to name it. Okay, the editor actually rejected right away. Well, like this can't be true. This is this study was endorsed by the ASMBS committee. How can you reject this? There's one big problem is that the response rate is pretty low, which I understand. We had to send to another journal. Okay, and but I still think most of the point from the paper is correct. Yeah, and I also think that it's very difficult for the ASMBS, the Bariatric Training Committee, to come up rules to limit the number. As Matt Hodder said that you cannot do monopoly. This is a free economy. It's against the law. So you probably the committee can increase the bar, saying that you have to do so many certain procedures. That's the only way. Yeah. But then to the current fellows and to the future fellows, what kind of advice we can give them? I think I'm not like a 100% glass is empty person. Okay. And we can also see there are some data Liz didn't show, actually is very important. I think 94 or 97% of people think the fellows think they are well trained. That's pretty good. And generally speaking, people are pretty happy. That's a very encouraging data. But from what I can think is that I think a few advice I can give you guys. Number one, I think that you should not think you're gonna be 100% a bariatric surgeon. Yeah. The good thing is that once you know how to do a bypass, you can do a lot of general surgery cases laparoscopic. Yeah. So you need to kind of market yourself as a MIS and a bariatric surgeon. Do not forget your general surgery skills. Yeah, I think that's probably my main advice. Yeah, I was just talking to the panelists that said if you find a new job and they hired you, let's say that at the OHSU, and they in the chair said, well, we'll hire you as a bariatric surgeon. But by the way, do you want to take some general surgery call? You don't have to. Your answer should be yes. I want to take the call because, as we know, this market is going to be tough. You may not be 100% a bariatric surgeon. I think 90% of us are not 100% bariatric surgeon. Yeah. You need to do general surgery. I think that's probably the main advice I want to give to everybody. Yeah.
I had two thoughts listening to the presentation and the two of you commenting on it. One is that I really don't think that these results are limited to bariatric surgery fellowship. In particular, I have a lot of friends in the HPB surgeonc world, and it is the exact same problem. They cannot find jobs in surgical oncology or HPB. And so they end up taking, general surgery, ACS jobs, and hope that they can find a surgeonc job or build a surgeonc job in the future. So that's kind of one thing that I think is interesting and speaks a little bit more to our medical system rather than bariatric surgery specifically, and how are we teaching our residents and fellows to think about looking for jobs and investigate looking for jobs?
Can I interrupt you for 1 second?
Yeah.
I think you had a great point. I actually gave a presentation to the UCLA residents and about a year ago. I say, what's happening in bariatric field is not only happening in bariatric surgery. It happens even more with endocrine surgery. It is happening with exactly what you said, HPB. Mm-hmm. And to some extent, actually, it's affecting colorectal. To some extent, colorectal used to have great, amazing job market as bariatric surgery 15 years ago. Why is that? I asked every resident, I say, why is that? Because the change of training pattern. I was telling them that 30 years ago, 80% of the general surgery residents, graduating residents, did not do a fellowship. Everybody was a general surgeon. Only 10-20% of people did the fellowship. Nowadays, completely reversed. 80% of the general surgery graduates are doing fellowship. What's happening is that we're overtraining the specialists. Mm-hmm. Another number I want to give everybody, actually, I have done some homework on this, is that nationwide, the peak bariatric volume is about 250,000 in 2019. And nationwide, the colectomy number estimated is about 300,000. And however, there are about 750,000 gallbladders surgery every year. That's about 1 million hernias surgery. So basically, it's like, okay, 80% of people are doing, like a bariatric HPB, and colon cases, versus only 20% of the surgeon left doing gallbladder and hernias. So actually, we have a huge need for general surgery. Actually, those jobs are relatively easy to find. Yeah, but a lot of subspecialties. I think we are not the worst. I think endocrine is pretty tough. Yeah, and HPB, if you want to do pancreatic cancer, it's like almost impossible. And it's very tough. Yeah. So I think this is because the shift of the training mode, the model. We are overtraining fellows. We are actually supplying less general surgeons.
Yeah. And 20 years ago, when people were graduating without doing fellowship, wanting to specialize in something like, say, bariatrics or surgical oncology, maybe more than 20 years ago, maybe 30 years ago,
30 years ago.
they would get a job first,
Yeah.
and they would build the practice in the location. And that whole dynamic has changed. And now people are trying to find jobs that are already existing rather than going somewhere and building a job. And so that kind of feeds in for me to my second thing I was thinking about, which is specific to bariatrics, in that I think bariatrics is harder than other specialties in some respects because bariatrics requires so much multidisciplinary ancillary services to be a successful program. And it takes a lot of capital to build a new program. And it's not just like you can hang up your shingle and be a general surgeon on day one. And then if it doesn't work out, you close the shop, which is what you can do for gallbladders and hernias, but you cannot do that for bariatrics. So I think that is part of what makes it so challenging to create, because we need more bariatric surgeons because there are so many people who need surgery that are not able to get it. And part of it is that there's not enough of us.
So I would add one level of complexity to that is that when you look at these numbers that Dr. Chen is talking about, this 250,000, well, if you look at the actual percent growth rate every year, the highest percent growth rate is revisional surgery.
Mm-hmm.
And so over time, we're doing more and more and more revisional surgery. Mm-hmm. So I think one of the pieces of advice that I offer to people who are really looking to be the most marketable out there is learn how to do the procedures that are going to be more on the front line 10, 15 years from now, when you're really at the peak of your career. So, learning the SADs and the duodenal switches, and then learning the revisional surgeries, that's really going to be higher volume than it's ever been before. And so I think that's also part of like, when we look at the makeup, yes, we need people out there doing primary bariatric surgery, of course. But also, I think revisional surgery is definitely something, that will add to your kind of toolbox when it comes to finding a job.
Yeah. And I think, maybe just making it a little bit more mainstream to consider that you may have to build your bariatric practice rather than getting a bariatric job right out of fellowship. And I think that was a lot more common in the past. And it's hard, and we don't do a good job of teaching residents or fellows the business of surgery, or how to write a business plan, or how to take that to a hospital administration, or how to get a hospital to do anything, because it's actually really, really hard to do that. But we don't teach our trainees how to do that. Everything is focused on the clinical side of medicine and surgery.
Lauren, to continue, the point that you made, actually is a great point. I also want to actually expand that a little bit. I think that nowadays, if you want to find do bariatric surgery, you want to find a good bariatric job in the locations such as New York, the Bay Area, Los Angeles, Seattle, San Diego, those highly desirable areas, it's going to be extremely tough. Yeah. Extremely tough. Those markets are completely saturated. Yeah. And I would say that if half of the surgeons in these areas I just talked about quit, still they probably don't need, they don't have to have new surgeons. Okay. However, another way to look at it is that if you really love bariatric surgery, and I do, and you need to think a little bit other places. I think recently quite many Duke fellows went to places like North Dakota, Alaska. Those areas. I think there's still need in those areas. Yeah, relatively underserved area. So you may have to pick. If you like what you do, you may have to go to the relatively underserved area.
Yeah, I mean, I'm not living in Oklahoma by chance. So, but when you live in a place that only has, I think we have only 5 accredited programs in the entire state.
Yeah.
There's a lot of opportunity for growth. But I do think it's really good advice for anybody in surgery at all, that when you're looking for your first job, you will never find a perfect job. And so you have to decide what your priorities are. And if the type of surgery that you're doing, or academic versus private, or, your partner or location, if one of those things is an absolute non-negotiable, then you might have to give up other stuff. So if it's non-negotiable that you live in Manhattan, you might not be able to find a pancreas job if that's what you want. Like, you might have to get a job that's more generalized. And if you absolutely want to do bariatrics, you might not be able to get a job in Los Angeles. You might have to move somewhere else, like Oklahoma, which is wonderful, by the way. And we have really good weather. So ignore the tornadoes.
As you mentioned, I don't want to, do this in my tiny house in Los Angeles. Okay. Another point I want to elaborate a little bit. Liz mentioned, one slide is this medication impact. Kunnor, and again, Kunnor and I have a little bit discussion, and she and I disagree. Okay, so let me give everybody my viewpoint on this. Little bit background is that I have noticed that in our program, we actually, since I came to UCLA, our volume has been increasing every year for the last, I've been here for 9 years. For the last first 80 years, almost every year went up, except the pandemic year, we were shut down, but pretty much going up every year. But this year, I noticed a little bit decrease of volume. So I texted a few friends, including Kunnor. Okay, I texted about 7 or 8. I was like, hey, what's going on? I have seen a little bit decrease of volume. How about you guys? Only Kunnor gave me a positive answer saying, no, I didn't see that. Actually, our referral is highest, ever. She's always positive. Okay, I like that. And another person said that, okay, it's neutral, our program director, this place, the old program director did a terrible job, and that was like, artificially low, and now we're getting, well, okay. But other 5, friends almost had the same feeling as mine. They say, okay, we have seen a decrease. Then we will try to understand what caused this. And I think, everybody, thought is the impact from Wegovy or Ozempic or semaglutide, same medication. And also, we also need to realize it's not only one medication on the market. It is one medication on the market now, one effective medication. Another even more powerful, tirzepatide, Mounjaro, is coming next year. When you read the data, the tirzepatide, the weight loss is about 22.5% total body weight loss. When you look at the nationwide sleep data, it's probably about 25, 26, 27%. The difference between the medication and the sleep is very small right now. So everybody, I want to remind everybody this history, if you don't know it. When I was a surgical resident, every year we had this, mock oral exam. The old attendant would ask us, what are you going to do with this perforated, gastric ulcer? Bill 1, Bill 2, are you going to do the vagotomy? Or like, shit, I've never even seen one. Why? Because that generation of surgeons, when they were in the golden age, in the 60s, 70s, 80s, every week they had to take at least one patient to OR for perforated ulcer, gastric ulcer, duodenal ulcer. But when the H2 blockers came, especially after PPI came, I only did one perforated ulcer in my whole residency, one in fellowship. So far, 2, here as attending. It's like minimal. So when there are 2 modalities that are the same effectiveness, efficacy, almost everybody's going to pick medicine. Okay, trust me, almost everybody's going to pick medicine. So I think that the impact of those medications on bariatric volume is going to be profound. I don't know. At this moment, I was telling quite a few of my friends that I know could not disagree with me. But my point is that I think nationwide we're going to see about 10 to 15% drop of volume nationwide. Kunnor, what's your point?
I don't think so.
Okay, all right. I'll give them some hope. Yeah.
And this isn't just a glass half full thing. I think so. A couple of things. Number one, the majority of patients who do well with these meds long term stay on them long term, and there aren't a lot of patients right now who really want to stay on these medications long term. Number one. Number two, how many can afford it? And number three, we haven't had any patients on these meds long enough to say that it actually really does work long term, that you don't have regain in 10, 20, 30 years. We're starting these patients on these meds in their 20s, in their 30s. That's 60 years of life left on these meds, you know, like we don't have enough data there. So I don't think that that's really gonna I don't know that that's gonna pan out long term. I don't think we can make that assumption. That's one thought. Another thought for me is that these meds have often been used on patients with lower BMI. Y'all know I'm in North Carolina. I don't operate on a lot of people with a BMI of 35, 36, 30, anything. And so, you know, a total body weight loss of 40 pounds versus a total body weight loss of 200 pounds or 100 pounds to be that, you know, whatever 25% is very different in the bariatric patient population that I treat. And so for me, these meds, yes, we often do prescribe them. And some of the people who come in their BMIs in the 40s and they try them and they really struggle because their excess body weight really is 100 pounds at least to get to close to an ideal body weight. And then ultimately what happens is they end up going down the surgical pathway. But I do feel I offer them to everybody who's interested because that's really part of the justification and the investment in the surgery is realizing that I've tried as much as I can and I need this tool. The other thing is that these medications, to me personally, I love them because it increases the awareness of obesity to everybody. Anybody and everybody is now seeing that treating obesity as a chronic disease is normal. Weight recurrence is normal. Staying on medications for obesity. There are people who, my mother is a vegan, not by choice. She's allergic to a whole bunch of stuff. And we're vegetarian. And so the way it panned out is that she can't really eat anything bad for her, even if she wants to. And her cholesterol was in the 300s, 400s, because we have familial hypercholesterolemia. Luckily, I didn't get it. But it wasn't until she stayed on medications for a while that her cholesterol actually came down and stayed down. So to tell somebody with a metabolic disease that they need to come off a medication, you know, lifelong, do they really want to do that? Is that something you can do? So I'm telling my patients, you can stay on this for as long as you want to, but what I'm finding is they don't want to. They really would rather at some point flip over to surgery. So this is really advertising what we do in a pretty positive way. If we use it right, it's a good tool for us. And then finally, I use it as an adjunct. I think a sleeve plus Manjaro is the best therapy there is for some people. It really does get rid of that chatter, that food chatter. You know, they have the surgery. They say, I still feel like I think about food all the time. I still feel like I have these cravings, and you start them on a low dose of the medication and they do really well. So using this as kind of a, you know, we have ERAS and we have, you know, the stop bang, and we have all these protocols for pain control and opiate reduction. And this is really multimodal therapy for obesity, which is where we are now. This is what we're doing, right? In 2023 for obesity treatment. And so I think this is only going to add. I think the meds are good for us. And I think that it's actually going to increase volume because it's advertising what we can do when the meds fail after people have tried them.
And I think we're going to see a lot more. I totally agree with everything you said. I think we're going to see a lot more people getting to the 90 to 100% excess weight loss with the combo surgery plus medications.
I agree.
And at the end of the day, that's what everybody wants.
Yeah.
They don't want to go through everything and still have obesity and be sitting at 39 BMI. Now, granted, when they're starting at 60 plus, it's really hard to get past 40. But now that we have all these really powerful medications that we can combine with surgery, you can get people into the 20s. And I think that the way the medications affect appetite gives you an inroad with the behavioral health interventions to help people develop the healthier eating habits without the really invasive thoughts about craving food. And so I totally agree with everything you said. And I think it's making obesity treatment mainstream. And there's just, my biggest worry is that 10 years from now, everyone in the entire world is just going to be on Ozempic in the drinking water. And we're still going to have the same rates of obesity or worse. But then we've lost like one of our treatment strategies. Yeah. Everyone is just on Ozempic or Mounjaro. So that's my.
Do we want to ask the fellows? Do they have questions? Yeah.
Yeah, we do have a question from the panelists. They're asking if you guys can comment on the growing field of hybrid therapy using endoscopic sleeve gastroplasty plus medications, and the increased involvement of gastroenterologists.
So we have a gastroenterologist who, in the community, not at Duke, but in the community, who does a lot of the ESGs. And I know there are a lot of bariatric surgeons doing them and gastroenterologists doing them. I personally don't do them yet, just because I keep looking at the data and I don't see it. Again, for my patient population that has the amount of weight to lose that most of my patients do, it's really not something that I can offer them with a lot of confidence as far as arriving at the goals that they want to get to. Number one. Number two, it's not covered by insurance. And to ask my patients to spend that much money on a treatment that I'm not sure is going to get them to their goals is really difficult for me, philosophically, especially when they could spend a little bit more and get a surgical procedure that I feel would probably serve them better long-term. So that's kind of where I am with that. But also, I've now revised some ESGs, and they're not super fun. The ones that I've scoped have been pretty gnarly. The sutures often will detach from the anchors and then become like a mucosal web within the majority of the body and antrum. So if the patient comes in wanting a sleeve, a lot of times after scoping them, I say, listen, we can go in and dig out all those sutures, but we risk damage to the stomach itself. Most of the time I've done a bypass now, and that's because the cardia and the fundus are relatively spared from those T fasteners and the anchors and the sutures. So I'm not saying it's a horrible procedure. It's just for my patient population who wants to lose more weight than an ESG is probably going to get them to. It hasn't been the thing. Now, Dr. Duncan's asking about, well, what about an ESG plus Mounjaro? And that's a great question, but we don't have the answer to that because we don't have any data on that. I hesitate because Mounjaro is GLP-1 agonist plus the GIP, right? So you have the gastroparesis, and that in the setting of the ESG, what's it going to do? It should theoretically do what it does with the sleeve, but you don't have the hormonal changes of having the decreased ghrelin. We haven't removed the antrum and some of that body. And so I think I hesitate to say you're not going to have weight recurrence and that Mounjaro is going to completely get rid of that. I think that the jury is still going to be out on that. We would need to definitely do some studies. And also, I think there's a good point here that the gastroenterologists are really the ones who are championing ESGs. And is that what we want? And endoscopically, as far as our skill set, I could certainly do it. I don't do it because right now I'm not behind it. But at the same time, if it's something that is going to grow in our field, is it something that we should be doing?
First time I agree with Kunnor 100%.
First time ever? Yeah. Oh, we're recording this right now, you guys.
And actually, it's interesting. I had a discussion with one of my friends who is a gastroenterologist who does this procedure at the UCLA. About a few months ago, I say my advice is that you can do it, but don't put your whole career on this. I say why? I say the weight loss you can achieve by ESG can be completely achieved by the medications. So then why do patients spend that much money out of pocket to do this procedure?
But I guess to Dr. Duncan's point, what about an ESG plus medications?
I never thought about that. Yeah, but I still think that I agree with you that when I look at the data, the efficacy is not that good. And the complication rate is not lower,
right?
And the revision is much harder. Why do I do that? And it's not covered. I don't.
Yeah, I think the only kind of devil's advocate is that at least the way I see it is as an academic bariatric surgeon, like it's part of my mission to advance our field. And so if things are happening in the field, I want to investigate them and explore and see, do they work or not? I don't have any personal problem with gastroenterologists doing the procedure, but if they're going to do an ESG at my institution, they're going to do it as one of my colleagues and be part of our bariatric program. And their patients have to go through our dietitian and psychologist and all that.
100%.
But I'm happy to have gastroenterologists be on board with being obesity treatment specialists as well.
Totally.
I agree that it's we just don't have enough data right now, and so it is still experimental. And in all of these things, we do not do ourselves a service as a specialty by doing a large volume of either procedures or medications that end up not working, because that is what puts a bad taste in the mouth of the primary care, internal medicine, and insurance companies to say, why am I going to pay for you to do a surgery every 5 years on somebody, because it's not working. And so I think we have to have a little bit of due diligence and make sure that what we offer is the best that we know at the time, and that we're not just throwing it out there just for fun or
for the fellows that think, current fellows, if you go out to establish a practice, I think you can get into this endoscopic, sleep field. There's nothing wrong with that. You can do that.
Yeah, and also, balloons, like it's a great choice for some people, depending on, do you want to lose 30 pounds for a wedding? Are we temporizing a patient who needs to get a different procedure?
Now you can completely achieve that with Wegovy, and you don't go through all those things. Yeah.
Yeah. I mean, I guess the question now is, what about a balloon plus Wegovy? What is that going to look like?
But I think I had another advice I would give the current fellow is I think there's some other model you can think about.
Yeah.
Is that, do you want to prescribe those medications?
There's a really good question, Yijun, real quick in the chat. Jason, hi, Jason. Jason Samuels at Bandy is asking us about how the ASMBS and Fellowship Council collaborate on accrediting and evaluating fellowships. Obviously, the Fellowship Council is responsible for MIS fellowships, but it can be opaque. So myself and Adrian Dan would love to shed some light on this, I'm sure. Fellowship Council and ASMBS work very closely. The requirements are uniform between the two as far as, what we expect fellows to accomplish in their fellowship. Adrian and I both sit on the Fellowship Council Accreditation Committee. So this is a committee that specifically looks at all of these requirements on every year, 2-year, 3-year cycle, depending on the program. And we go through and we talk with current fellows, we talk with past fellows, we talk with, program directors and faculty. It's a very interactive process, depending on, how long it's been and where the institution is in their growth period. But Jason, this is a very vetted and, intensive process as far as evaluating fellowships and making sure they're up to snuff with the accreditation process. So just to put that out there. And the ASMBS, I'm actually the liaison from the ASMBS to the Fellowship Council for this particular purpose.
And I don't know how, I'm sure it's very well advertised, but there is a bariatric certificate that you can apply for at the end of your fellowship that goes actually through our committee. So it's the Bariatric Surgery Training Committee, and we host this happy hour. But then we review those applications every year for getting your bariatric certification. And that essentially kind of has a list of all of the procedures and didactic education and research that we think is kind of what should be expected to have a comprehensive bariatric education.
And there are lots of committees that the ASMBS has that for the fellows out there, please join, get involved. We'd love to have you. I think part of what's great about ASMBS is that there are those of us who are mid-career, there are some of us who are kind of later in our careers, and we'd love to have people who are newer in their careers kind of come and add their new voices. So take a look at the website. It's all listed there, and there's a really easy application to get to too.
Mm-hmm. Now, if people are looking for bariatric jobs, do you guys have any suggestions?
I kind of dread this point in the conversation because I'm at a point of privilege here. So I am the fellowship director of one of the oldest bariatric and MIS programs in the nation, right? So my network is gigantic. I literally can find out where my fellows are going and call somebody occasionally if a job, wasn't necessarily in existence before, it may come to fruition. So I definitely have a network and a place of privilege that a lot of fellowship directors don't have. But what I will say is that a lot of the jobs in the minimally invasive surgery and bariatric surgery world aren't necessarily advertised, and people didn't know they needed them until your fellowship director calls or you send them a letter and they realize that you're the person that they need and they just didn't know they needed it. So that is definitely more prevalent in our field, I think, than it is in some other fields. And you don't, so I hesitate to say this because I know some fellowship directors are going to be like, please don't tell them that. But I ended fellowship and I didn't have a job. I didn't have a lot of time to interview, and I didn't see, there were no jobs that I really wanted. I wanted to be close to my family. I knew I wanted to start I wanted to start a family. I wanted to get pregnant. And so I had a lot of requirements and a lot of boxes to fill. So I did locums for a few months until I found what I wanted to do. And then ultimately, signed on for a job. So there are a lot of ways to get jobs. And mine was actually the place that I did locums at. They said, hey, our staff has never talked about a locums provider the way they talk about you. Would you like to stay here and start some bariatrics with us? So there's a lot of ways to find a job. And it just depends on what your requirements are. So I think we often feel pressure from the outside about this is the job that I have to have. Really evaluate what makes you happy and what you want to do, because that changes from medical school to residency to fellowship to being an attending. Your life will change, your values will change, your philosophy may change. So I think some reevaluation there is important.
My advice, I think I pretty much gave, and look at some of the underserved area. And also, I think Kunnor said was right. Actually, sometimes you may take a little risk. You can do some locum sometimes, because everybody's looking job at this time point. But actually, maybe in September, October, less people looking, And we also have quite a few people I know that they did locum and then they found a job a few months later.
Mm-hmm.
Also, another thing is that don't be afraid of those like MIS type job or even general surgery job. I think you can take it. Sometimes in many places you get one foot in the door. Once people like you, there are many other opportunities may come. Still, we are better than endocrine surgery, I would say.
Yeah,
Much better than transplant.
I do think there's a lot of anxiety, obviously, because you've spent 7, 10 more years, in surgical training plus medical school and maybe grad school and all this stuff. And now all of a sudden you're at the very end and it's like, what if I don't get a good job, whatever that means to you? And it can be really scary, for sure. But I will say that, from the perspective of someone who's been out of training for a little bit of time, people change jobs all the time in surgery. And if your first job is not your ideal job, it is changeable and it's okay. And if you think you got the perfect job and you get into it and 6 months in, you're like, wow, this is not the perfect job for whatever reason, it's okay. And you can just continue to search for what you want. And there's no harm in, taking a job that isn't perfect for a year or 2 or 3, and then just waiting until the right opportunity comes along.
Laura,
I think that's a great point.
I want to share some data with
we agree again.
You guys, There's so much content tonight.
You go ahead, Yijun.
Actually, during residency, I saw this data. I did not believe it. Okay, when I saw the data, I did not believe it. I think it's on the surgery news or some sort. They say that 42% of the general surgery graduates change their job within 2 years. I was like, that's too high. That's like almost half of the people change job like within 2 years. That means that a lot of them are not happy with the first job. So I graduated, residency in 13, fellowship in 14, and I have seen my friends, very close friends, the last few years, almost exactly the same. About half of my friends change job within 2 years.
Mhm.
So what Laura said is totally right. It's okay for you not find a perfect job to begin with, and keep looking.
Liz, any comments, questions from your side of things, having reviewed all this data?
No, I think the big points were things that we've rediscussed, that there's going to be medical adjuncts for our surgery, and looking where you weren't necessarily expecting to look can probably find you the best job that you weren't even trying to find. So
Yeah.
I want to add one thing. I mentioned my prediction for national volume. I said 5 years, okay, because beyond that, it's very hard to predict. And I wish actually Kunnor is right and Laura is right this time. Okay, I wish that I'm wrong. Okay.
Awesome. Well, thank you all. It's 8 o'clock, so I'm gonna wrap it up. Appreciate you all for joining us this evening, and our next happy hour is going to be a video session, and that will be on June 22nd. And we'd love to have you all join. I think that's going to be coming up right on the end of fellowship. Certainly, if anybody is interested in presenting, please just send us an email. We really want to get anybody who's interested involved. Yeah, have a great night.
Thank you so much.
Thank you, Dr. Chen and Dr. Jain-Spangler and Dr. Sodomin. You guys did awesome. It was a great session.